Hello, welcome to Healthcare in America, an overview of the healthcare delivery system in America for professionals just beginning their healthcare journey. This is a final project for Nursing 302, Business of Healthcare class in the RN to BSN program at McNeese State University. If an American needs medical attention or wants to get a checkup, the way they interact with the healthcare system depends on many different factors. That's because the healthcare delivery system in America is complex. Let's call our generic Americans Jack and Jill. For Jack and Jill to participate in the healthcare system, they must deal with providers, with payers, and know where to go. Providers include physicians, other advanced practice providers, imaging services, or hospital systems that often include all these providers under one roof. Providers offer their services in outpatient and inpatient settings. Payers consist of the government, private insurance companies, and individuals. Through these various elements, Americans receive the care they need to get better and to stay healthy. In the American healthcare system, providers can be considered as both the individuals who offer their services and the institutions where these independent providers work. Providers include those individuals who make decisions about a patient's care, such as physicians, advanced practice providers or APPs, which include CRNAs, nurse practitioners, and physician assistants, and also pharmacists. Providers also include businesses who offer ancillary services, such as labs and imaging centers. Then there are hospitals that house all of these providers in one facility. Standalone practices may range anywhere from one provider to many different providers for outpatient care. For example, close to my home, one practice is called a multi-specialty clinic, offering mental health services, physical exams, labs, imaging services, and even minor surgery. Providers are basically the merchants of Venice. No, not Venice, but the merchants in healthcare, as they have the goods that people need. And as the ones who are selling the goods that consumers needs, often life-saving measures, they have a great influence on healthcare equity. The interaction between providers, payers, and clients to form a quasi-market in America has led to elevated costs and inequity. But we will talk more about that at the end. In this system, providers can create inequity by offering services that are so specialized and expensive that insurance companies will not cover it, which means only a few will be able to access it. For example, consider proton beam therapy for cancer treatment. It is now a proven treatment covered by many insurance plans, but not by all of them. If both Jack and Jill are recommended for proton beam therapy, but Jack's insurance covers the procedure and Jill's does not, to pay cash for the treatment will cost around $100,000 or more. But after being out of work for a year and paying for other treatments, Jill does not have that kind of money. What will she do? This is an example of a costly, specialized, life-saving treatment that may not be covered by insurance, and so people are left behind. Some may say, left to die. Another example of inequity is the fee-for-service model. Michael Chernow, professor of healthcare policy at Harvard Medical School, says the following: although the fee-for-service model pays for a vast amount of useful care, it also funds considerable amounts of low value and unnecessary care. Consequently, it is routinely blamed for the healthcare system's fiscal ills. The fee-for-service model is based off of huge coding catalogs published by the insurance companies with thousands of services covered and how much they will pay for each service. However, trying to set one universal price for the same concept across the board can be tricky. In addition to that, unscrupulous providers may order extra testing or procedures to be able to charge the payer more money. This is also known as insurance fraud. At the same time, these extra tests and procedures may be justified by practicing defensive medicine, where the provider feels the need to protect themselves from a potential lawsuit. While Jack and Jill have a right to ask for an itemized bill of any medical visit, the bill is full of abbreviations and technical language that is almost like reading another language. This makes it hard for the average consumer to understand exactly what they are paying for. Providers can address inequity by offering services to clients who are unable to pay. Emergency rooms are required by federal mandate to do this, and that is why many emergency rooms are so full and busy. If both Jack and Jill are brought to the emergency room by an ambulance after a car accident, if Jill has insurance and Jack does not, they both must be treated and stabilized. Here are some fun facts about emergency rooms. Did you know that only about 13% of people who walk into the emergency room are admitted to the hospital? And that nearly 20% of all visitors receive no diagnostic testing, so no labs or x-rays to find out what is wrong. It is a whole nother conversation to talk about why this happens and how to alleviate overburdened emergency rooms. But these are some good numbers to know as a nurse. Additionally, some providers offer a limited number of services to the needy. For instance, it is common for psychologists to offer their services on a sliding scale based off what the client thinks they can pay in agreement with the doctor. If both Jack and Jill go to visit Dr. Smith for depression, Jill, the successful lawyer, will be expected to pay the full rate of $250 an hour, while Jack, the broke college student, will pay the sliding scale rate of $75 an hour. So let's switch gears and consider where Americans go to find healthcare. For most Americans, the first step will be an outpatient setting, such as a physician's office, an urgent care center, or the emergency room. Yes, the emergency room is considered outpatient, but the most expensive out of all these options. The largest number of healthcare encounters will be in the outpatient setting. Only if Jack or Jill need more serious interventions or close monitoring will they be admitted to inpatient care at the hospital. Other inpatient settings include psychiatric hospitals, nursing homes, and different levels of rehabilitation centers, such as skilled nursing facilities, inpatient rehabilitation facilities, and long-term acute care hospitals. The National Institute on Aging recommends that each person seek the long-term care solution that meets their needs, recognizing that our needs develop gradually over the course of our lives. Where Jack and Jill receive care affects equity. Generally, outpatient settings will be cheaper than a hospitalization. So outpatient settings can address inequity by offering more economical services. The Affordable Care Act, or ACA, expanded access to outpatient care with the belief that an ounce of prevention is worth a pound of cure. Being able to delay, shorten, or avoid hospitalization altogether. So if Jack has regular annual checkups, and at age 50 his primary doctor discovers high blood pressure and high cholesterol, the conditions are then managed through medication, lifestyle changes, and regular checkups. At 65, Jack's condition now warrants open heart surgery. He is discharged 5 days after his surgery directly home. Jill, on the other hand, leads a similar lifestyle as Jack, but never visits the doctor, and at 57 has a heart attack while at work. The ambulance brings her to the hospital, and she is rushed into emergency open heart surgery. She is discharged 2 weeks later to a rehab facility and 4 weeks later to home. If those are their only major medical events, it is likely that Jack will have spent much less overall on healthcare, lost less time with his family, and lost less income from work, as he was already retired at the time of his surgery. So in this case, we can see how an ounce of prevention is worth a pound of cure. Outpatient clinics can create inequity when they limit appointment slots for patients on Medicaid. Even though there may be room on the doctor's schedule, if they have already met their minimum quota of Medicaid patients for the month, they will not be given an appointment until 1, 2, or 3 months later. Outpatient settings that are community clinics help to create equity by offering subsidized services at greatly reduced cost. And certain rural facilities, both outpatient and inpatient, provide equity by bringing healthcare services closer to where people live. While not exactly the Wild West, if the closest doctor is an hour or more away, and the closest hospital farther than that, health outcomes drop with less primary visits and emergency services being so far away. You've heard the expression that time is money. Well, in healthcare, time is often life. Many of these facilities receive federal funding, or in some cases, physicians will have their medical school loans paid in exchange for several years of service in a rural area. Inpatient settings create equity by offering services to anyone regardless of economic status in the emergency room, as already mentioned. They create inequities when highly specialized treatments are not available except to the very wealthy who can pay out of pocket, since often not even the best insurance will cover these services. Thankfully, there are studies that have shown that since ACA, inpatient costs have been contained somewhat, although they are still expensive. Earlier, we mentioned the various long-term care settings, all of which were inpatient. Now, ACA tried to make it possible for more long-term care to take place in patients' homes, both because most people prefer to stay in their homes as long as possible, and because it is much cheaper than a nursing home. Nursing homes can cost anywhere from $5,500 a month in Texas to more than $19,000 a month in Alaska. The University of Wisconsin published a report in 2019 directed by Mary Haman about the states that participated in the Balancing Incentives Program, which was a part of ACA and intended to incentivize states to spend more money on developing home care solutions. Home care could be in the recipient's own home, with a loved one, or in an assisted living facility. After receiving health care, it has to be paid for. All Americans know that health care is expensive, and worrying about how to pay for it is a top concern for most people. There are 3 major payers in the American healthcare system. The government pays for services for certain individuals through various programs. TRICARE and Veterans Affairs pays for health care for active service members, veterans, and their families. Medicaid pays for those with limited resources. The exact income level varies by state and number of people in the household. And finally, Medicare pays for all Americans 65 and over. However, some may choose to carry private insurance in addition to Medicare through their employer. Now, it is estimated that about 2/3 of all Americans have private insurance. Most of those are employment-based plans. And then finally, some people pay for healthcare out of pocket. Here's a quick overview on how each of these payers pays for healthcare services. The private individual who pays out of pocket is straightforward, paying for services rendered immediately, just like when you buy groceries from the store. To have private insurance, you pay a premium. When received through an employer, the employer will pay for a portion of the premium. Some government programs require their participants to pay premiums, while others are free based on qualification criteria. After that, both government programs and private insurance work in similar ways to pay providers for services rendered. They have pre-negotiated rates with providers and will reimburse them accordingly. Most programs have some sort of cost sharing where the client pays a part of the bill through deductibles and copays. After the client reaches the maximum out of pocket, then the insurance will pay for the rest of their medical expenses for that calendar year. So for example, Jack works for Big Mart and pays $50 a paycheck for medical coverage, while Big Mart pays another $250 per paycheck for his insurance. If Jack goes to the doctor for an annual physical, it is probably free. But if he goes because he got sick, he will pay in full until he reaches his deductible of $1,000. After he spends $1,000 on medical care, then his plan may offer a 30-70 split for copays. So from then on, he will pay 30% of all his medical bills until he reaches his max out of pocket. If his max out of pocket is $3,000, once he spends $3,000, the insurance company will cover 100% of the rest of his covered medical expenses for providers who are in network. There are a lot of nuances to this, but this gives you the basic idea. Having a multi-payer insurance system creates inequity in U.S. healthcare because it creates a quasi-market which allows prices to be artificially inflated. In a single-payer system, which means government healthcare for everyone, the government negotiates the rates for everyone. They usually can negotiate a better rate, but above all, it reduces administrative costs and guesswork because everyone receives the same coverage at the same cost no matter what provider you go to. The multi-payer system and quasi-market has led to rapidly increasing healthcare costs. America has the highest cost per person for healthcare of any country in the world. In 2022, healthcare costs in the U.S. were about $12,500 per person. The closest followers were Switzerland and Germany at about $8,000 per person. And America was more than double the UK and Japan, who are under $6,000 per person each. Although Americans are paying more for healthcare, the average life expectancy in America was only 76, while it was above 80 in the aforementioned countries. The quasi-market is further complicated by the fact that most Americans receive their healthcare through their employer, who has a conflict of interest in having healthy employees to increase productivity while trying to maximize profit for their stakeholders. In 2022, about 54% of all Americans received healthcare through employer-sponsored insurance programs, and thus are 2 steps removed from the negotiation of how much they pay for healthcare. There are 5 insurance companies that control about 50% of the private insurance market, and Medicare alone is the largest payer of healthcare in the U.S. So it is fair to say that medical prices across America are determined by these 6 organizations. This is concerning, considering we are talking about healthcare, an essential product that everyone should have access to. That is why there is a seemingly endless debate about healthcare policy in America. But that is a topic for another day. This was a quick overview of the healthcare delivery system in the U.S. I hope that some questions were answered, while I hope that I pointed you in the direction to ask even more questions. As healthcare professionals, hopefully we can be part of creating a more equitable, efficient, and cost-effective system. Before we can initiate change, we have to understand what needs to be changed. Thank you for watching.